All right, we'll get started. Welcome, everyone. This is for this academic year, this is our first Global Minds Local Insights Mental Health Research Scholar Series. For those of you who are less familiar, the Global and Local Center for Mental Health Disparities here in the Department of Psychiatry hosts a series of speakers. We started last year and had 6 speakers, and we're able to have them come and visit us for some time. And this year we have our first collaborative events between psychiatry and / pediatrics in a way. And we're really excited to have this first speaker of the series this academic year. The series is sponsored by the Peter H. Knapp Funds in bringing lectures devoted to research in the field of psychiatry to the Boston University School of Medicine Department of Psychiatry. Peter Knapp was a former faculty member here at BUBMC and did a lot of great work in psychiatry, and this was in dedication of his dedication to psychiatry. Our speaker today, I'm really excited to introduce Dr. Nicki Dawson, who will be presenting on Decolonizing Infant Mental Health for South Africa, a contextual and community-based approaches. She is a clinician researcher and counseling psychologist from Johannesburg, South Africa, is the research development and training lead at Ububele Educational and Psychotherapy Trust, a mental health service and training center in Johannesburg, South Africa. She obtained her doctorate in psychology through the University of Witwatersrand. Her doctoral research investigated the cultural and contextual applicability of infant mental health and attachment constructs for the South African context. She also works as the clinical lead for Ububele Parent-Infant Services, which includes a basket of locally developed and adapted infant and maternal mental health interventions, including Ububele's home visiting program and a neonatal consultation service, which she developed. Nicki's work also involves supervising and training practitioners in contextually relevant parent-infant psychotherapy, and she holds an honorary lectureship position at the University of Stellenbosch as part of the Masters in Infant Mental Health program there. She also runs a small part-time private practice in Johannesburg with a focus on working with adoptive families. So very productive, very busy. It's wonderful to have you here, Dr. Dawson. Welcome.
Yeah, thank you so much to everyone for having me all the way from South Africa. I have a lot to do in the next hour, so I'm going to rush through some things so that we can have some time for questions. But I'm going to be talking, as Maria said, about decolonizing infant mental health for the South African context. So hopefully I'm going to start just with introducing you a bit to infant mental health for those for whom it is not a familiar area of work. And then as we do that, examine some of the models that we are using and approaches we are using for implementing community-based infant mental health interventions in South Africa in low resource settings. But the focus of my talk really today is to think a little bit about identifying and critically evaluating potential biases in existing infant mental health theories, research, and intervention, and really to focus to share some of the strategies that we have used to explore decolonizing infant mental health for our setting. So just to get us started, the field of infant mental health is really developed originally out of the field of attachment theory, and then really been flung forward by advances in neuroscience, which have shown how much brain growth and wiring is happening, particularly in the first 1,000 days of life from conception through to 2 years of age, particularly related to our social functioning and our stress response system, the wiring of our HPA axis during this time, and showing really what implications these early relational experiences then have for our later functioning throughout our life in realms that I think people really didn't expect initially. So of course, having a big impact on our cognitive functioning and mental health and social relating, but also having a real impact on our physical health, because of the tax of early stress experiences on our cardiovascular system. So this has really sprung the field of infant mental health forward in the last probably 20 years, where we are thinking more and more about the social, emotional, and cognitive well-being of infants, diagnostic categories for infants in the mental health field, and really trying to address experiences of behavioral, developmental, and regulatory distress for young infants. And now that we really can appreciate that infants too can be depressed, they can be anxious, they can be stressed, right? But it's also really a field developing around prevention and trying to focus on promoting later outcomes through really driving preventative interventions across the world. And these interventions are usually focused on promoting the quality of early relational experiences or the quality of parenting that infants are receiving, because we know how central the parent's role is in developing early healthy brain architecture. So this has really resulted across the world in organizations like UNICEF taking up the charge to try and promote child outcomes and promote the Sustainable Development Goals through targeting parenting interventions. And the Nurture and Care Framework, which is endorsed by UNICEF, has as one of its 5 components responsive caregiving, really trying to promote parenting in a responsive way in the early years to promote lifelong child outcomes. And so contexts like myself, where I'm situated in Johannesburg, South Africa, are increasingly receiving funding to roll out responsive caregiving interventions or implement mental health interventions in our setting. In particular, and this is shared really with other low middle income countries, global South or majority world settings. So from that background, I want to quickly take you to our setting, because it's really important for us to with this backdrop of research and theory, zone in now into the experience of trying to implement a responsive caregiving intervention in the middle of South Africa, in a previously Black designated township area. So I'm just going to show you a short video showing some images from Alexandra Township, where I work, and then I'll talk to you a little bit about Ububele. So that gives you a little bit of a sense of our setting. I mean, South Africa is notorious for its inequality. We are a country both with very high levels of privilege and financial access, but also of great poverty. And Alexandra Township is particularly kind of a place which demonstrates this inequality, as it sits adjacent to Sandton. I find the richest square mile in Africa. But it was an area under apartheid that was designated for Black residents, and really suffered from a lack of infrastructure development, and remains an accessible and affordable place for many South Africans who cannot afford to live within the urban areas, but need to access their jobs close by in proximity to Alexandra Township. And Ububele, where I work, is located within Alexandra. South Africa is also very well known for high levels of violence, and a lot of this is concentrated in areas such as Alexandria, where gender-based violence rates and intimate partner rates are very high. We're a country also with quite high levels of unemployment, sitting at over 40% nationally, and in places like Alexandria, this would be much higher as well. So Ububele was founded in 2000, right at the end of apartheid, by two clinical psychologists who really wanted to post their involvement in the anti-apartheid struggle, provide a way to support the healing of South Africa through mental health service delivery. And so they set up the center called Ububele, which is an Nguni word for kindness. We are both a training center, training mental health care professionals within South Africa, but also providing services directly to residents of Alexandra Township in a community-based setting. And as I said, this was really a mandate that came trying to support healing post-apartheid. So I'm not going to be talking about Ububele in its entirety today. I'm really going to be focusing on our infant mental health programs, which I have been involved in. But our services extend to child and adolescent psychotherapy services. We provide a lot of group psychotherapy services. We provide a lot of parenting courses. And we provide training to healthcare professionals, as I said, on pretty much all of the services that we provide as well. But today I'm really going to be focusing on our basket of infant mental health services, which I'll explain in a bit more detail. So this is an image from a service called the Baby Mat, and really informed by these principles from attachment theory and from neurodevelopmental research, are trying to promote responsive caregiving in primary healthcare settings. So here, for example, the mothers and babies in the background are gathered at a primary healthcare clinic to receive their their immunizations and baby weigh-ins, and we would give a brief talk about infant mental health and invite parents to come and talk to us about their concerns about parenting and their support needs. And Ububele's infant mental health services have really evolved from that starting point of the Baby Mat. And we are now also connected into the local hospital settings where we provide consultations to families who have had neonatal grief, neonatal diagnoses, birth trauma, obstetric violence experiences, etc. And now also provide a WhatsApp-based support service for families as well in a similar way. We also make great use of the tool developed here in Boston, the newborn behavioral observation tool, which helps parents to understand the regulatory support needs of young infants, so that they can provide responsive caregiving. And through those services, those consultation services, we are able to identify families at risk and service about 400 families through manualized interventions and psychotherapy services. Okay, but what I really want to talk about today is about context and our process as an organization of trying to ensure that what we were doing in our service delivery was ethical and mindful of bias. And we know that the Western world is weird and that that much of what we know about child development and child outcomes really comes from culturally and contextually biased samples from the weird world, and from parents who are parenting under very different circumstances and conditions with very different outcome needs for their children. And we were very mindful of this at Ububele and really wanted to ensure that while we were bringing services to Alexandra, we were thoughtful about this. And really, I think trying to avoid epistemic exclusion and the decimation of local knowledge systems and local practices. Because really the risk, if we do not do this, is framing difference as deficit. So yeah, in a majority world setting, like the one where I'm situated, we wanted to find the balance. How do we provide mental health services, but also interrogate potential acts of colonization in doing so? The question more, though, for us was, how do you do that? Because no one really had a manual for us on how to go about that. And so what I'm going to share with you today is really our journey of trying to find a way to do that ourselves. And we're going to talk through, I guess, what are coming to kind of come together for me is 5 steps that we've taken so far, which is really just a beginning point for us. So when Ububele started, a lot of our adaptation was really kind of practical considerations about our context, right? Drawing on the basic premise of public health ideas of what we should be doing and what's good practice. We knew that in our context, there was a real lack of healthcare professionals. We didn't have a lot of funding to roll out interventions. There was a lack of racial and linguistic representation in the healthcare professional groups that we had access to. There were huge barriers to accessing mental health services, and there was a real lack of space and privacy. We weren't going to be given a consulting room in a clinic to offer mental health services, and so we had to find ways to provide services. And so we've really drawn on, as I say, kind of quite common public health practices. All of our services are community-based and take community-based formats. You see here an image of one of our staff working outside someone's home in their yard. And this is really how we work. We're working on the floor. You see in that previous image on a mat in a public health care clinic, really screened and creating privacy through the bustle of the clinic. And as I say, working more online and other formats that make mental health services accessible to families. We've also engaged heavily in task shifting. So what you see there is an image of our community health workers. These are local mothers from Alexandra Township themselves. They are high school graduates, and they were trained, they were selected, carefully selected and screened, and trained in mental health intervention. And we're the first non-healthcare professionals in the world to provide the newborn behavioral observation tool that was developed here at Harvard, and hugely successfully are now, I think, exemplars of what can be done. We also engaged in a lot of co-development with our community health workers and beneficiaries, really looking at our intervention materials and thinking together about how to adapt them. But this has really not sufficed. I think it really didn't allay our concerns about potential colonization through mental health service delivery in our setting. And in particular, we were involved in a randomized control trial, and I'll share a little bit about that, where a lot of this was really stirred up for us as we became aware of how the interventions were being designed and the tools that were being used, and really felt a sense of discomfort about how things were being operationalized on the ground. So as a starting point, we were directed to anthropological literature. And this was a really helpful exercise for us to just start really understanding the variance in parenting practices across the world. As I said to you earlier, parenting in the Western world is very weird. It's the outlier in terms of how the majority of the world, 90% of the world, are parenting their children. And so to really understand, for example, how much Americans kind of have a lot of affect in the way that they engage with children. This is not common in our setting, even for myself as a South African, as a white South African. It's very uncommon to kind of have a lot of affect in the way that you engage with an infant, for example. For us to really kind of see through anthropological documentation just how odd it was. And I think we were really aware of this as we rolled out these interventions, to expect families to sit and play with toys on the floor with their infants. This is the realm of siblings in our context. This is what siblings do with one another, not what adults do with children. Also, the dominance of really requiring and scoring negatively parents who are not very verbal in the way they respond to infants. And we've been thinking a lot about this, about how we would really observe what we considered responsive care of infants communicating distress, being picked up, being regulated in their affect by physical contact, really receiving negative kind of scoring on psychometric measures because of a lack of verbal responsiveness that you might find in a context like America. We also were really kind of coming to learn that the facilitation of learning that was expected of parents looked very different in the measures and in what was described in literature from the weird world than what we were seeing. A lot of the focus of the literature was on the facilitation of cognitive learning. And we were really seeing kind of a gap, actually, in socialization-based learning. How much our parents in South Africa were focusing their time and attention on teaching their children cultural values, local values, ways of engaging in community settings, and not worried so much about the color of something, but still teaching their children something really important. So again, a useful starting point, but not entirely helpful to us. And so we tried to look at data-driven ways of engaging with colonization. So one of the things that we did as part of the randomized control trials, we looked at the baseline scores of our families, where we could see very low mean scores and very little variance in the scores, and went back to the measures that were being used to measure their responsive caregiving, and we were able to identify what was driving the low scores within our context. And this was a very helpful starting point because it helped us to start understand what behaviors actually, what are some of the ways that we operationalize parenting in the weird world that differed from what was happening in our setting. And a lot of what we saw is things like non-responsiveness to non-distress signals, that in our context, parents were losing scores on responsive caregiving measures because they weren't responding to non-distress signals, right? Or because they weren't using verbally based teaching like we'd seen in the anthropological literature. Or that they were kind of what is often in this literature considered intrusive, that they were setting the tone of the interaction with their infants. And this really left us with questions. How much of that can be explained by the stress that the people living in this context are under, and how much of that is actually benign cultural difference or contextual adaptation? Which again took us back to some of the literature, which has been a really interesting experience of finding that these findings are very common in other majority world settings and in other populations of color in the United States. So Susan Woodhouse and Jude Cassidy and their colleagues really found the same, that what is often considered on responsive caregiving measures as intrusiveness, a very loaded word, I think as well, and also non-responsiveness to non-distress signals were not key predictors of attachment security in Hispanic and African American families here in the US, which is very similar to what we had found. And the same, a study in Pakistan really showing that there was much less a response to what they call divided attention tasks. So basically when the mother is conversing with, engaging with the researcher, how responsive is she to the infant signals during that divided attention task? A task with huge power dynamics, with huge cultural complexity embedded in it, really. And parents are in those moments, I think, teaching their children about respect and teaching children about kind of cultural ways of being. And this was being coded negatively. And similarly, this was found in Pakistan as well, low levels of verbal responsivity. Then we looked at some other data. So we looked at measures of mentalization. I don't know how familiar people are with this term, but this is really looking at a parent's capacity to think about the mental states of their infants. And again, found really low mean scores and very low variance in the scores of the mothers in our population on these gold standard tools of parenting measures. But what was much more interesting to us was being able to show that there wasn't a relationship between this and child outcomes, and there wasn't a relationship between this and some of the things that we anticipated that there would be relationships with. What there were, which we were not expecting, were relationships with things like disclosure of abuse. So people that were doing well on parenting measures were our abused mothers, for example, mothers that were disclosing that they had been abused, which didn't make any sense to us. So we went and looked at the qualitative data to try and make sense of some of this. And we're really able to see how people's mentalizing scores were really linked to things like their citizenship. The people that were disclosing that they were in abusive relationships were legal citizens who knew that if they reported this, that there was help and support for them, as opposed to the people that were living without legal status in our context, who were also not mentalizing, not because they couldn't, but because they didn't want to tell us anything about what was going on in their lives, right? They didn't want to tell us about the abuse that was happening. They didn't want to tell us about their legal status, etc. What we also found, which was incredibly interesting to us, we expected that if there was a match between the interviewer and the interviewee in race and language, that we would get higher mentalizing scores. We found the opposite, which I think really highlighted for us how much cultural bias is in this test. Because when people were code switching, they could demonstrate their mentalizing capacity on a weird developed tool. But when they were engaging with someone that was familiar to them, in a language that was familiar to them, their way of being was very different. And I think this really highlights it for us, how biased these tools really are. Another thing that's been really interesting for us is a process we're kind of calling knowledge tinkering. And I guess often in the realm of intervention rollout, there is a big focus on fidelity and maintaining fidelity. And we actually were able to step back and say, we're going to teach a bunch of concepts and think about a kind of bunch of research with our community health workers, and then really step back and let them document what they do and what they talk about and what they don't talk about and why they don't talk about it. And how did they tinker with the knowledge that we've given them? How did they align that with what's local knowledge they have? What do they disregard as absolute nonsense? And what do they really take on and hold on to? And it was really an interesting process. So our research question was, what divergences are there between kind of the academic knowledges and the local knowledges, and how are these documented by our community health workers in their implementation reports? So we were able to draw on 12 sets of transcripts. So these are 12 intervention transcripts of 10 to 14 visits per mom. And you can see an example of the kind of document. They write extensive notes on what they've done in their intervention. And when we did a thematic analysis of these intervention notes, and we're able to identify some really interesting things. So, for example, one of the key principles that we're teaching in responsive caregiving is around responsiveness and discriminate responsiveness. It's a key principle of attachment theory. But what we really came to learn is that although the community health workers aligned themselves with this knowledge and relayed this information to families, the local mothers did not take this. They thought this was absolute nonsense. And they were really explaining to our community health workers how much this teaching was going to impact on really important transactional alloparenting relationships that they had. They were leaving their children with their neighbor, and the neighbor needed to not be too bothered by their infant. And so really teaching an infant that they could expect response every time they made a big noise and made a big fuss was really kind of going to be damaging to these relational networks. But other aspects of what we were teaching, like, for example, that an infant is sensing and sentient, that an infant can see and hear directly after birth, this was information that was known locally to be untrue. Infants were known and understood in South Africa, and are known and understood to not be able to see or hear directly after birth, at least for the first 3 or 4 months of life. We used the MBO to demonstrate to families that how infants are able to see and hear. We had very high levels of fidelity within the intervention. The community health workers really took this up. They wanted to show everybody in the community that this was the case. And mothers were very convinced by this and took on this knowledge very happily. And we've had similar experiences, for example, like best infant feeding practices. So there's obviously a lot of information, and particularly linked to the nurturing care framework, about concerns around early solid feeding and things like this. Again, the community health workers were taking up this knowledge and sharing this knowledge and passing this on according to their intervention transcripts. But mothers, again, were really resisting this and really explaining back to mothers that there was huge concern about, for example, leaving a baby at their neighbor's house and not knowing when they would be fed again, or what kind of food they would have access to, and really finding it really important to ensure that infants were receiving adequate nutrition before they left them, for example, with somebody. Another kind of area of divergence that we identified was around how child development and behavioral problems were understood. So although there were kind of frameworks for understanding around kind of stimulation and input, and even neurodevelopmental related causes, locally there's really an understanding that that child development concerns are the consequence of being cursed or of ancestors not favoring you. And what was really interesting for us around this was to see how both the mothers and community health workers integrated, in this instance, different knowledge systems. And this was a realm really for them where these things existed alongside one another, that both were always considered true. Sorry, so I've really spoken to, this is kind of a summary of this. But I think really highlighting for us these ideas around that alloparenting in current times in our context is really more of a transactional exchange for people, and that this has implications for child rearing practice. Also really understanding local epistemologies and ways of thinking about development and how this is incorporated alongside kind of academic or medical understandings. But then also, I think really importantly, what this process highlighted for us is something that we were speaking to earlier about how parents were really sharing with us that their objectives and goals were not just their child's developmental outcomes. That was of concern to them. They were in concern in their child's school achievements and financial advancement, but really trying to kind of convey back to the community health workers and the community health workers back to the healthcare professionals how important socialization goals were, how important community goals were in the ways that they're parenting, and how our theories and kind of research we're not supporting these outcomes. And so I think this is really highlighted for us as an organization, and I hope as a communication to the world, that as we're thinking about the development of interventions and the rollout of mental health services, we really need to be holding alongside different outcome goals and outcome agendas. You know, how do people kind of navigate their context, and manage in their context is equally important as an individual child's developmental outcome. Something else that I wanted to just share about that is kind of really taken our attention. This is our team on Heritage Day. We celebrate on the 24th of September every year the diversity of South Africa. Part of what we've really been thinking about as well is this phenomenon across the majority worlds of task shifting, which is becoming more and more common, this idea that we can address the dearth of mental health services in the world through training up community health workers. But I think our observations had really been that our community health workers were then experiencing a lot of strain through the tasks that they were then asked to take on. And so we engaged in some research, really trying to inquire about the well-being of our implementing staff and looking if the support structures that we'd put in place for them were sufficient to protect them from burnout and secondary traumatic stress in particular. So we engaged in a national study in collaboration with the South African Parenting Program Implementers Network to survey 209 community health workers, their management staff, and the support staff working alongside them. This was a cross-sectional mixed methods explanatory sequential design. So we did a quantitative survey and then 33 interviews, as well as 28 participants engaged in photo voice methodology, where community health workers, managers, and support staff could take photos of things that represented burnout and secondary traumatic stress experiences to them. And just a little bit of information about our sample. 54% of the sample were frontline workers, 24% management, and 22% support staff. And we had really had in place a lot of what internationally and in weird contexts is considered the key supports to have in place for mental health professionals. So they had access to regular reflective supervision, 80% of them. They had access to professional development opportunities and to counseling support through their organizations. And the consequences of that were felt. So people really did feel supported. We saw that according to international benchmarking studies, we were sitting quite high actually on people's perception of how supported they felt within their work and their levels of compassion satisfaction. So we're the dark blue on this graph. And so really we could see that our staff were feeling supported and felt like what they did mattered and was helpful to their communities. But despite this, they had very high levels of burnout and secondary traumatic stress. And we don't have international benchmarks for moral distress, but this is really a measure which is looking at I think in the States, it's mostly looked at how much people feel that they are not able to make provide the most moral or just outcome to their patients. What we were really looking at is how much people felt that their community members had access to kind of what they needed and that the just outcome would happen, but quite high levels of these things. And so what we were really able to start to show is that reflective supervision really seen as this important guard against burnout in minority world settings was not sufficient to support the well-being of our staff. And this was, I think, is really importantly demonstrated when you look at the frontline worker and manager sample together. There was a significant impact of reflective supervision on burnout and secondary traumatic stress scores. But when you really take away the sample who has the most privilege and the most financial access, you see that these effects fall away. And it really speaks, I think, to kind of the more economic drivers of these things within our context and the injustices within our context. So just to share, I've goodness raced through this. So we'll have lots of time for questions. But what are our next steps? So really at the moment, we are kind of taking more of a step back to try and really understand what are the worlds of infants in our context like. And really I'm going to be drawing on these community health worker transcripts to try and document more of what are the kind of child rearing frameworks that people are engaging in our setting. How do they work? How are infants living? What are they navigating? And what are the concerns of the families that are receiving our interventions? And how do we align our interventions with their realities, their worlds, and the family's social development goals? And then we have also applied for a grant, which we will find out about in February, to really then be able to quantitatively investigate what are the best predictors, not only of individual child outcomes within our setting, but then also of these social outcomes, these collectivist goals that local families have. And so we're really going to be looking more in depth at this in the coming years. Okay, so where does this leave us? So I think for us, we are kind of where we're sitting more and more today is that there is still much colonization in infant mental health theory. And one real central area of this, I think, is in the idea that there is a universal parent. There are parenting behaviors that everybody should be doing more of. We increasingly feel that this idea is highly colonized. And that actually in a decolonized infant mental health practice, we need to appreciate that there is a context-adapted, contextually varied parent who is responding to their individual context. The second idea, I guess, that we feel is a colonized idea is that there is a universal outcome agenda. That for all children, we're trying to achieve the same outcomes that can be measured by the same global tools. And that again, this is really context and culture dependent. It's culturally specific and it's context adapted. There are different outcome agendas for different children sitting in different contexts, and we need to be mindful of this in the intervention studies that we run. The next is this idea that context is a moderator of developmental pathways. And I think we in South Africa are very tired of this idea, right? That this is how child development works. And then when you throw poverty in the mix or you throw stress in the mix, it messes it up. It changes the developmental pathway. Context is not a moderator. It necessitates diverse ways of being, and it also is a creator of benign difference. And so we really need to understand that context is an important variable. It's not just something that negatively impacts development. And then also really this move away from individual developmental goals being centralized and to the expense of and the ignoring of social collectivist goals. And it's not to say that one shouldn't be centralized over the other, but that they can coexist. Yeah. And then in relate to our support for implementers, this idea that there's one way to support the well-being of mental health professionals across the world, and that we need to move away again from these universal ideas and really think about in majority world contexts what kind of support needs to be put in place for mental health service providers. And again, I guess just to really reiterate some of these ideas, I think what we are learning is that diverse ways of being are necessary and important, and that their survival, their development, and their developmental value and their social value really needs to be better understood. And really, when we can better understand, when we can address the cultural and contextual sampling bias in child development research, it will benefit everybody. And also, yeah, that I think what we are also learning from our context is that divergent knowledge systems really can coexist. Families want new information, they want information from the weird world, but they are able to understand how to integrate these knowledge systems, to discard what needs to be discarded and to take on what is useful. And we need to really allow for that process to happen, and be allies for people in that process of navigating contradicting knowledge for themselves. And then again, really, that this task shifting agenda is really helpful, I think, in providing service delivery, but it cannot be at the expense of the service providers who themselves are community members, and we really need to think about ways to support them as well. So really just thinking that, kind of some of the essentially used ideas of task shifting, co-development, and community-based formats are really helpful starting points, but they are not where we need to end. We really need to think about other strategies. And as I say, really thinking about not only construct validity and measurement validity, but outcome bias. What is our bias in what we think people need in order to do better and be happier and benefit from their lives? There might be very different ideas about this. And also really thinking about unanticipated impact. And I think this is something that we are really thinking more and more about, because we can kind of be drawn into this idea that if we run a randomized control trial and we show benefit on an outcome tool that we've chosen, that we've guarded against harm. But we may not realize, while we haven't measured, we don't know what harm we've done to the derogation of local epistemological ideas. So just, I guess as a summary to kind of think through our process, we found it really helpful to really draw on anthropological literature, but also really let mixed method studies help us understand child development in our context. And again, as I say, I think this kind of experimental exercise of letting fidelity slip a bit and really seeing kind of how do people integrate knowledge systems has been a really helpful process. So as I end, I guess I just want to share really our journey has really been about finding a balance. Of course, there is useful knowledge in the weird world that can benefit South Africans. But we also know that there is much kind of parenting practice or cultural practice that is not necessarily good for children. But our goal is really to never fall entirely into one of these camps, right? Where either everything is right because it's culturally the way that it is, or something is right because science says it's right. But to really find the balance, and I think that sitting in that place has been most helpful for us. Okay, thank you. That is me. If there's any questions, those that are online, you guys are hearing now, okay, correct? Yes, great, okay. All right, so if we have any questions, in terms of, there's one, maybe we can start with that one in the chat, Dr. Dawson, and then if you speak, because those of those who are online, just try to speak really loud so they can hear, and then if Dr. Dawson, if you can repeat the question before answering, thank you. I see the first question from Kimberly is, does anyone have any resources on self-efficacy and maternal mental health care that they could share here? Don't know if anybody has any, not that I know of. Yeah.
I have a question regarding, I thought it was really interesting, the idea that you had mentioned about, or what the findings, that the moms are saying that they can't, at least from what I understood, they can't be too responsive to their kids because they need the neighbors to take care of them, they can't, and they need to be able to behave well. And then how that kind of doesn't roll with our ideas of how to develop a healthy attachment. Was there discussion on like happy mediums, or do we You know, how did moms, how was that conversation had?
Yeah, I mean, I think there is a kind of sense perhaps on landing on a happy medium. But I think for us, it's also about going back to attachment theory. I think this is where we're kind of hoping to go with the grant and actually see kind of how much this is true in our settings, because there hasn't been enough research on alloparenting and attachment. So I think more than anything, it's just kind of caused us pause for thought, than landed us on a particular way forward. Because I think, again, it kind of, even the research that has been done on alloparenting and attachment has really been more in a kind of communal caregiving setting where people aren't, it's not a transactional experience. And so, you know, I think it's interesting to think kind of about the research that's been happening here, about that there is, you know, really something also again about responsivity to distress and non-distress that's coming up again and again. That actually, if children are for the most part having their distress responded to, that their attachment security is predicted by that experience. So I think where I'm kind of leaning, or maybe I should just say have questions, research questions, is whether or not actually that's what's necessary, is, you know, just to ensure that there's responsivity to distress in the infant. Again, that maybe doesn't have benefits for cognitive development, but it has real life social benefits in the here and now. So then it's really for parents, I think, to weigh that up. You know, do they want to make sure that their relationship with their neighbor is intact as it possibly can be, that their child has a secure attachment because their distress is being responded to by parents and neighbors, but that their cognitive development might be compromised because of that. You know, I don't know. That's for parents, I guess, to choose. Yeah, I don't know. Yeah.
Yeah, first of all, I want to say thank you. I really appreciate this presentation and the grounding and the colonization kind of work. And as a result of colonization, a lot of people have stigmas in mental health care. And I'm wondering if that's something that you've experienced in your work and how you respond to that.
Yeah, I mean, I think that is a common experience in our context as well. I think we perhaps have dealt with that mostly by often disconnecting ourselves from a mental health service, kind of because we're community-based and because we're parenting focused. Those are not terminologies that get associated with us that much, even though we are psychologists and mental health professionals. But I think also kind of really come to understand, again, that this stigma is really about local understandings of what it means to be, to have developmental difficulties. You know, it's about, often for people, it's understood as really being about being cursed or not favored. And so there is a lot of shame associated with that. And I think that's what's been so interesting about kind of how people are integrating those ideas with like academic or medical ideas. And we really are seeing people not letting go of those kind of local ideas, but I think finding some relief in the idea that they can do something about their child's developmental difficulties or their mental health struggles. You know, I think I don't know if that answers your question, but I think it's partly that we kind of don't have to package ourselves as a mental health service always, allows people to access us, but also that people are finding relief actually in some of the frameworks that we bring to them around that. Yeah. And also really engaging in community-based formats. So I think like a WhatsApp-based service has been incredibly helpful for people that can access something without anyone knowing that that's what they're doing. Yeah. Yeah.
I wonder, you know, back to this issue of alloparenting and the bias towards cognitive outcomes in weird reason. If you had to speculate and expand upon the idea of how collectivist emotional regulation, parenting, that emphasis that you're observing plays out over the long term? What would be the long-term outcome? So, cognitive people are obsessed with third grade achievement or vocabulary size and second grade.
Yeah.
What are the things you would be interested in seeing as the outcome?
Yeah, and I'm realizing, sorry, I'm forgetting to repeat the questions for the recording and for those online. So the question was like, what are the outcomes that might be of interest to us in our setting, I think, if not cognitive outcomes? I mean, I think there are things like capacity, like affect regulation capacities, or capacity to share, or tolerate frustration, or or empathy, or kind of um, community care. How much are people concerned with the plight of their neighbor and will do something about that? I think this is part of what's local ways of being are teaching families to look out for one another, to care for one another, to be mindful and considerate of one another. I think those are outcomes I'd like to really show are supported by these ways of parenting. Yeah. Which are, things that kids in weird contexts struggle with a lot of the
That's
time.
right. And big
Yeah.
gap.
Yeah, celebrating someone else's success and not competing for yeah.
Good question, John.
Aha. Okay, so it says fantastic presentation, excellent work. Has there been any similar work done with middle-class moms in South Africa? I'm just wondering about removing the poverty and perhaps finding very similar results. So not yet, I think largely because of where our service is situated. But that has been a research interest, I think, to really look at that, as well as not just middle-class moms, but I think moms that aren't in the urban settings and faced with so much of the stress of the kind of dense population setting. I'd be really interested to look kind of at more rural settings as well, where others, kind of violence and other issues like that are less of a driver of parenting behaviors. So yeah, thank you for that question.
Hi, thank you for presenting again. You talked about some of the downsides of task shifting and the burdens that your community workers were facing. And I'm wondering if you have had any ideas about how to better support them or have a different model that possibly works better.
Thank you. So the question was about ideas for other models for supporting the community health workers. In that research is kind of really still in the middle of happening. And what we have planned for when I return to South Africa in January, in early January, we're going to be having some participatory action research focus groups with the community health workers to share these results with them. They haven't actually seen some of these results yet, to think with them about what they need. I think what's really coming up from the qualitative interviews, though, is the kind of impacts of inequality on their well-being. And so, I think really what we're leaning towards is lobbying for funding models that supports medical aid, medical insurance for our community health workers. Leave benefits that you'll be able to take leave, if you've experienced a traumatic, if you've been witness to a traumatic experience work, that you have employee benefits which provide you with respite and services like that. So I think it's really about building those kind of basic employee benefits into people's care. And then I think we're also quite curious about the relationship between kind of ways of coping in our context and things like polyvagal theory, which are really showing kind of how valuable somatic experiences can be for regulation and well-being supports. A lot of people, what they are using to cope and manage as well is kind of spiritual coping and religious coping. So how can we build more support for that into the kind of system? I think is something we're interested in, but also things like singing and so, but I don't know, because it's, I think, needs to be created by them, and that's the plan. Last question?
I think I have one question. I was
Yeah.
trying to formulate it. I love the presentation. And just a few things that really struck me was I love the language of interrogating colonizing practices, interrogating decolonizing practices, and also the example of the needing the child to behave for neighbors. So really kind of highlighting and centering local knowledge, decentering the role of therapists as expert. And I also love the intersection of, like, as a mental health provider myself, that anthropology, I kind of see it more akin to anthropological work. And so my question is, yes, there's the decolonizing practices, and just as a mental health provider, are you doing work around like deconstructing why we have this decolonizing, colonizing kind of thing going on? And what is your experience with that? Because I would love to hear, especially being in South Africa, where the history of apartheid is so fresh, what that's like for you. I think that's part of the work.
Yeah, in the kind of broader mental health context. Yeah, I mean, it's been interesting. I've been here. So the question was kind of what is happening, is that right? And kind of in South Africa around thinking about colonization in mental health care more generally. Is that right? Is that your question?
Yes, and on that deconstruction practices, bringing it into the mental health work.
Yeah. I mean, I think it's an interesting thing because I think in South Africa, a lot of the training is very focused on this, I think, from very early, but we're still at the mercy of not having the resources or the kind of research programs to develop new things. So I think it's kind of a very cerebral exercise, but there hasn't been a lot of opportunity to develop new tools, new assessment tools, or new actual kind of what's the word I'm looking for, that we can then take into our work. So I think there is a lot of thinking about deconstructing, but there's not a lot of reconstructing because there's resources are needed for that. It's less of a cerebral exercise. But I mean, I think that's what's, South Africa has been such a critical place for this in the world, I think, because of our history and because of how, people like Nelson Mandela have helped us really think about how do we talk about this, kind of a year after apartheid ended, we were having these conversations already. And so I'm really grateful for that they are common conversations to have. And, we really had to face, we were at the beginning of using psychometric testing to discriminate against people of other races. That's what was, happening in our country. So it's, I'm very grateful that we have a lot of conversations about it and we think about it. I think that's kind of, first day of undergraduate school, these are the conversations as mental health professionals that you're having. But we haven't, I don't think, had the opportunity to reconstruct something necessarily. Yeah, because the world is moving, fast with lots of resources around us. Yeah, sure.
You, everyone. I take one final moment both to thank Dr. Dawson, who's been here with us and been able to provide multiple different talks and really engaged in discussions with our trainees, with our faculty, with staff. It's been really fantastic. And a special thanks to Martha Viverts, who has been an amazing host. She's an associate professor in the pediatric and psychiatry and in CMTP, as many of you who are involved know that. And she's been an amazing host for Dr. Dawson and came to us to collaborate on having Dr. Dawson join us. And we're so thankful for that and we appreciate it. And to our participants, I actually saw we had a number of our colleagues in South Africa on the call, and which is really lovely, and through the AGMHI as well. So thank you to all of our participants who've joined us in their evenings, and to everyone here who's come, who I know have busy schedules, but came to join us both online and in person.